Alliance representing Australian Sickle Cell Advocacy. If you can see, I'm the founder and the executive director of this organization. We are here to raise awareness. Our organization started online about 7 years ago, and during the pandemic, we decided to come back because we know this is what we've been doing forever, and it's just easy to reach people, not only in Australia, but worldwide, and we're excited with what we do. So before I go ahead, I just want to acknowledge the traditional orders of the land in which we work, even if we're doing this virtually. I pay my respects to the elders past, present, and emerging. So I'm excited to have my guest today. We connected on LinkedIn, and anyone who's in sickle cell is my best friend online on social media. I do this because my daughter was born with sickle cell anemia about 12 years ago, and the first 5 years were the worst years of my life, but I decided to do something about it. I decided to stand up and support other people when I couldn't find that support in Australia. So without further ado, I'd like to welcome my guest, Dr. Angela Henry. How are you this morning? And lovely to have you this morning.
Thank you so much. I am doing well. I'm doing well. Thank you for inviting me to this platform to really talk about something that's near and dear to my heart, which is sickle cell disease.
Yes, and I'm excited. I looked at your biography, like she's just the perfect person to come and highlight the work that she does. And this year we are focusing on, our organization is focusing focusing on raising awareness, advocating for newborn screening in sickle cell disease. People will be surprised that, Australia is a developed country. Up to now, you don't have newborn screening in Australia for sickle cell disease. We don't. A few months ago, my home country is Zambia. We're just launching the newborn screening, and I wrote to the Federal Minister of Health that a developing country just or commissioned newborn screening. What's happening to Australia? So we put in our application last year, and the process is really long, but we've gone through the first stage where they've accepted. It's in full review. After the full review, and it's got about another 6 steps before it can actually be commissioned in Australia. So for us is to continue having these discussions, and hopefully at the end of it all, it will be implemented in Australia. But at the moment, it's not. We don't have any newborn screening at all. We have a bit of prenatal screening. It's not mandatory across the country. It's where you are, depending on which hospital and which doctor. So again, that's something that we'll be discussing in the future. But at this point, it's all about my guest. She's got a presentation for us today. The topic is about sickle cell disease and labs. And we deliberately picked that topic because we're going to emphasize on newborn screening and other tests that you need to do in sickle cell disease. But before we do that, we like knowing our guests. We like this intimate chat so that our guests and the viewers can know who you are. I did put a small little bit biography online, but I would want to hear it for you. Who's Dr. Henry, and how did you come to talk about sickle cell disease? Thank you.
Thank you. Well, Dr. Henry is actually first a wife and a mother and a lover of all things health-wise. I actually do have a consultancy that I help healthcare professionals with their career coaching and things of that nature. In regards to sickle cell disease, it has really become a passion over time for me. I have a certification in adult gerontology and acute care, as well as family nurse practitioner, and I'm doctorally prepared. And so my road to sickle cell disease is one that really came to me, so to speak. I knew I wanted a specialty, and so I really sought out hematology. The best thing for me, I think I can say, is that I have sickle cell trait. And so for me, that was a push to really be able to advocate for those who have trait as well as sickle cell disease, because the journey is not easy for these individuals who live with this disease process. And so I'm just so fortunate to be able to have this opportunity. I have done research in sickle cell disease. My patient population is adults. Those who are 18 and over. And I'm also an assistant professor at a university in Memphis, Tennessee, in the United States.
Oh, thank you. Thank you so much for that biography. I did read, but I just said, it's better if we get it from you, because I might mince my words when I'm reading. It's better it comes from you. So I'm excited, and we've got a few people joining us. So Thank you so much. Again, before I know you're going to do an education session for us, but we like also just knowing a little bit about yourself. You've touched on the point of having a sickle cell trait. So obviously, maybe I shouldn't assume at what point you knew that you had a sickle cell trait. Growing up, did you know anyone who had sickle cell disease, or even if you knew about sickle cell trait in your community, did you think like, what's this? How come people talk about this condition?
Interesting enough, I did not know anyone growing up with sickle cell trait or sickle cell disease. And I vaguely remember when I was 12, my mom mentioning to me, I think you have sickle cell trait, or when you were born, I think they told me you had sickle cell trait, but I don't really know what it is. And they told me you will be fine. So that was the end of it. And so you fast forward, I fall in love, I get married, my husband and I conceive. At this time, I'm a healthcare provider. And so I said, wait a minute. I vaguely remember this discussion with my mom. And so I went ahead and asked my obstetrician to give me a test so I can be tested for sickle cell disease, sickle cell trait, just so I can be sure. Because at that point in my life, in my career, I knew the importance of genetic counseling and what we would need to do moving forward. And so sure enough, I was screened for sickle cell disease, and I have sickle cell trait. Our daughter actually has sickle cell trait as well. And so my husband was screened at the same time. We went ahead and did this together, and he has normal hemoglobin. And so that means for us, any child that we will have the potential of having sickle cell trait, getting one of the genes from me, or normal hemoglobin. And so we have two beautiful children, one with trait, one without. And so now it's very important for us to carry on that education and teach them about genetic counseling and moving forward and what to do. It's a tough decision to make, but we definitely have to if we want to try to eradicate this disease process as much as possible.
Yeah, it is. It's a very difficult decision to make. I know for you, at least you had that decision. So at what point did you get tested? Was that before you got married, or was that when you're just about to actually plan a family?
Actually, it was while I was pregnant,
Mm.
which makes it, for me, it didn't make it tough because I knew that even if I had sickle cell trait and my husband had sickle cell trait, that we would love this baby, we would nurture this baby, but it will really help for us to make those decisions for future pregnancies. But it's mind boggling. I'm already pregnant, and the what ifs that come along with it. And so with that experience and having those emotions, it's very important for me to teach people, you have to go ahead and get tested, pushing sickle cell trait testing so you'll know.
Yeah, no, that's really important. But again, it's a very difficult decision. For me as well, I tell myself that if I had known if there was any prenatal screening, because my first two babies were born in Zambia, then the two were born here. If I had known from the first pregnancy, would I have done things differently? It's a very difficult decision. It's a very difficult decision. And these days, people are living okay with sickle cell, especially in developing countries. So there's that, you can say this baby will be fine and I'll take chances and it's okay. And we are hoping one day there will be a cure. This will be a story of the past for us to sort of use the coin to say what if. So, well, that's very interesting. So you have spoken about specializing in sickle cell disease in your career. What made you decide to go that path?
Really, a lot of it had to do with the patient population. I noticed a group of individuals who were underserved, who were overlooked, who looked like me, who needed to have that care and understanding of their disease process. And so it really became more of a ministry for me to really be able to help my patients understand their disease process. The stories that I would get is that they knew about sickle cell disease, but no one really took them seriously or never really explained to them their disease process and how they can do things to make it better. And so for me, it was really giving them that push, really encouraging them, really making sure that I was bringing awareness. And so it just became one of those things where it was more like family with my patients. And I know that's also one of those fine lines that we have to make sure we don't cross, but I really wanted to make sure that they were getting what they needed in regards to good quality health care and understanding and being able to advocate for themselves appropriately.
Yeah, yeah. So my next question was going to be, which I'll still ask, how's the job satisfaction when you know you've deliberately picked this career? For me, also, it's very similar. I'm from a corporate background. I worked as an auditor back home in the tax office for about 10 years. Came here, worked in the bank. You know, I was wearing high heels. I was dressing up. I love dressing up. And then a deliberate move, I decided to come and start nursing because I wanted to understand my child's illness. But out of that came a career to work in the health industry. Would I go back? I don't, not really. There's just something that, you know, there's something in me, even if I don't manage or treat or care for people living with sickle cell disease, but I work with people to make a difference in people's lives. So for you picking that path deliberately, how good does it feel to make a difference in people living with sickle cell disease?
Really, really can't find the words. It's indescribable, especially when you have your patients who tell you how much you mean to them, that, you're pouring into them and that you're helping them through a process that they otherwise would feel defeated in. But in regards to just the satisfaction of it, that brings me joy. That lets me know that I'm helping, I'm making a difference in really being a change agent in my career, but more importantly, being a change agent in the lives of those who are living with sickle cell disease that I can physically touch on a day-to-day basis. The truth of the matter is, it's not all glamorous. We talk about, I love dressing up too. I love high heels, but sometimes you're in the trenches. Sometimes you're faced with things that really block what it is you're trying to do for your patients, insurance being one of them. And just, it goes on and on and on. And so even this is not the discussion today, but when we're talking about sickle cell disease as a disease process, it's literally head to toe. And we sometimes leave out those psychosocial issues or concerns that come along with it, and the concerns with the caregivers. And so it's a battle day to day just to get through, especially when there's sometimes a little that you can do. You can't fix everything. So sometimes it can be a struggle.
It could be a struggle. And I did sort of learn the American health system when I was doing my nursing. It was also, I learned about the American health system, Australian and the UK, and I think one or two European countries. Unfortunately, I don't know whether I would live in America if I knew that I had a chronic illness. Your health system is scary, to say the least, but I'm hoping things will change in the future. With us here, as taxpayers, I contribute to the healthcare system, and my healthcare is free. So my daughter had a bone marrow transplant, and it was free because I contribute to that. So hopefully things change for the American health system. It's scary, the things I read online.
It is scary. It is the gaps in care, not being able to get what you need when you need it. It is very scary.
Yeah. So before we go into your presentation, just two more questions. Where do you see sickle cell research maybe in the next 5 to 10 years?
Sickle cell research is really evolving. And so I'm so proud about that. We can see a number of different medications that are in the pipeline. I really can see true treatments for cure outside of bone marrow transplant. I see us moving into that era of more awareness, more advocacy, and hopefully, to your point, just more of a country being able to support the disease process itself and pouring in what's needed in regards to funds for treatment. And I think research has a huge part in making sure that those things are done. We have to have the evidence to make sure that we're able to properly take care of our patients. So I'm looking forward to all of the research that's on the horizon for sickle cell disease, because it seems like it's just coming out of nowhere. We were silent for so long, and now we have these different projects that are on board, and it's very promising, to say the least.
No, it is very promising. And I think one of the things that I feel has really worked, I think in everyone's favor in this world, is social media. Now we can stand up and speak to the highest person of the land and say, we demand this, and people can listen. We are doing this, and people can see that we are talking about sickle cell awareness and people are listening, and I'm actually excited to see what's to come. And a cure is just around the corner. So, well, thank you so much. At least I sort of understand where you're coming from, your personal journey and your job satisfaction. At this point, maybe we'll go into our topic. You should be able to share a screen if you've got a PowerPoint presentation, and I'll follow through with any questions from there. So you can go ahead and share a screen. Thank you.
I will get ready to share my screen. Are you able to see the screen?
Yes, please.
Can you see the screen, Agnes?
Yes, I can. Thank you.
Okay. Well, without further ado, we will just go into this presentation that's titled CBC and Sickle Cell Labs, and what do they mean? So this will be an explanation of sickle cell labs, and we will follow up with something that's very important as well, which will be the newborn screening. So today on this agenda, we will briefly define sickle cell disease, review the pathophysiology of red blood cells in relation to sickle cell disease, as well as discuss CBC and the test components therein. We'll review the role of blood counts in relation to sickle cell disease, and then discuss newborn screening. After that, we will have a Q&A session to close out the program. So what is sickle cell disease? It is the most common genetically inherited autosomal recessive blood disorder. So what does that mean? An autosomal recessive blood disorder means that there is a disorder that has a gene for each parent. So each parent is a carrier. For parents, for those with sickle cell disease, they have a mother and a father that probably has sickle cell trait. One has the carrier gene, which is an S trait, and a normal hemoglobin, which is characterized by age, just the normal gene. So they have a sickle gene and a normal gene, and that constitutes for an autosomal recessive blood disorder in regards to sickle cell disease. And you see this pedigree here, it shows just that, a mother and a father, both with sickle cell trait, in the instance of them having a child with sickle cell disease. In this instance, what I want to really point out is that there is a 25% chance with each pregnancy, if two parents have sickle cell trait, that they have a child with sickle cell disease, and that is with each pregnancy. So moving forward, just talking about the pathophysiology of sickle cell disease, here we see these healthy red blood cells. And then we also notice that these healthy red blood cells are filled with hemoglobin that carry oxygen throughout the body. In regards to sickle cell disease, the oxygen is deoxygenated or taken out of the red blood cell itself through a mutation that takes place in a genetic code for hemoglobin. And when this oxygen leaves the red blood cell, it leaves us with this red sickle or crescent moon shape. This red crescent moon shape, a red blood cell, actually causes breaks down of the red blood cells themselves, causing hemolysis and anemia, which leads to other complications in sickle cell disease. And so more importantly, I wanted to really look at the blood counts and what that means. So blood is made up of cells in the bone marrow, and the bone marrow is actually the core of the bone. It is distributed into the body through blood vessels in the bone marrow to do very specific tasks. And so even with this picture here, we can see that within the bone marrow, we have the blood stem cell, the red blood cells, white blood cells, and platelets. And we will go into these different blood products now. So in regards to a CBC, it's actually a complete blood count. It is a group of tests that evaluate the cells that circulate in blood. The CBC is used to evaluate overall health and detect a variety of diseases and conditions. And so that's why providers typically draw blood so we can look at these specific numbers. Here we see the different types of these cells. There are 3 different types, and there are red blood cells, which help aid in oxygen and CO2 exchange throughout the body. And we also have platelets, and they help with blood clotting. And then we have what's called white blood cells or leukocytes. And you can see here that there are 5 different types the neutrophil, the eosinophil, basophil, the lymphocyte, and the monocyte. And all of these white blood cells actually help to fight against infections. Here's just a picture of a common CBC that we may have. You can see here on the side where the white blood cell count, red blood cell, hemoglobin, hematocrit, MCV, all of these are part of the CBC itself. And down here at the bottom, this is what we would call a CBC with differential, meaning that we can see those white blood cell components here. And then these are just some typical, what we would notice as normal labs. Now, the normal range for labs really depends on the laboratory itself. So it can change a little bit from laboratory to laboratory, and maybe even a little bit from country to country. So here, let's talk a little bit about these red blood cells. Again, they are made in the bone marrow. They carry oxygen to the body. They remove carbon dioxide from the body, which goes to the lungs, and then it's exhaled out of the body. They typically live 120 days in those individuals that do not have sickle cell disease. But those who live with sickle cell disease, these red blood cells can live 10 to 21 days, and then they're regenerating. That's that hemolysis that takes place because these red blood cells begin to break down and burst and hemolysize throughout this process. And so here in red, you just see what this normal value would be for a typical laboratory in the United States. Now we want to talk a little bit about the hemoglobin versus the hematocrit. I always tell my patients that it's important to know your baseline hemoglobin and hematocrit. And knowing your baseline really sets the stage and precedence for your treatment, whether or not you need blood products or blood transfusion for treatment. So here we can see that this is the red blood cell and the oxygen molecule here that's attached right near the hemoglobin molecule itself. So again, that same process I mentioned before, oxygen from the lungs, you have that, then the oxygen bonds to the hemoglobin, and then the oxygen is released to the tissue and cells, making sure that you're getting good oxygen tissue perfusion and circulation throughout the rest of the body. So this is what happens with normal hemoglobin and hematocrit. The hemoglobin is actually a protein in the red blood cell that carries oxygen to the tissues of the body. The hematocrit is actually the volume percentage of red blood cells that are in the blood. And so here, this is just a depiction of a hemoglobin molecule, which is actually a protein. So the hemoglobin is made from 4 different beta globins. 4 different globins. 2 are a beta globin, 2 are alpha globins, and then it's attached by 4 hemes. Those heme molecules actually contain oxygen, and it's the oxygen we need to get that tissue perfusion going. And so here we can see that this is more so the sickle mutation that takes place that leads to polymerization, which causes sickling. So polymerization is actually the process or that cascading event that happens when there's a mutation in the gene that codes for hemoglobin. And with that mutation that codes for hemoglobin, there's a switch of amino acids that takes place. And so when that switch happens, it actually deoxygenates the red blood cell and causing polymerization. This polymerization actually causes those fibers within the red blood cell to stretch, causing some intracellular sickle fibers. And when that takes place, we can see here from this blood smear that you'll have some red blood cells throughout, and then you'll also have these sickle cells that occurred due to that mutation and due to polymerization. Again, so hemoglobin versus hematocrit. There is a rule of thumb for the calculation of hemoglobin and hematocrit. And typically what we see is that, go back one, what we see is that the hematocrit is actually about 3 times more than the hemoglobin. And so that's a good way for us to be able to figure out what if you know your hemoglobin, we can basically almost figure out what your hematocrit is or should be given plus some or minus 3 on that scale. And so here, for an example, we can see that this is an individual that could have a hemoglobin of 7 grams per deciliter. So if you multiply that times 3, that gives you a hematocrit of 21, plus or minus 3, just kind of depending on that scale itself or the percentage of hemoglobin. So that's the rule of thumb for calculating hemoglobin versus hematocrit. Now, moving along, I just want you all to see these 2 slides. So this first one, blood smear here, is someone who has hemoglobin SS, which is considered to be the most common and severe form of sickle cell disease. But I typically say if you have sickle cell disease, then all genotypes are severe. And here we can see that the hemoglobin is 6 to 9 grams per deciliter. That's typically the baseline for this particular genotype. And the genotype is actually the type of sickle cell that you have. Here for hemoglobin SC, is considered the more milder form. You can even see the difference. With SC, there are more red blood cells in circulation that you can see here. And thus their hemoglobin is a little bit higher. They have about 8 to 12 grams per deciliter in regards to hemoglobin. So reticulocytes, what are those? Why do we look at reticulocytes as providers? Reticulocytes are immature red blood cells. They do mature in the bone marrow, as we discussed before, how the blood is actually made in the bone marrow. The reticulocyte count is used to determine the number or percentage of reticulocytes in the body, and it is a marker of red blood cell hemolysis. What's really important is that typically individuals with sickle cell disease will have a higher reticulocyte count. And the myth is that if your reticulocyte count is high, then you're in crisis. Well, that's not necessarily true. Your reticulocyte count is higher because you are making more red blood cells, immature red blood cells that are going into circulation to help oxygenate your body, because these individuals are typically anemic. And so we really look at these counts here just to see how many immature red blood cells are in circulation and what that does and the impact that it has on our patient population. So a little bit about white blood cells. Again, they do help to fight infections by attacking bacteria and viruses that invade the body. And this normal range here is typical for most laboratory facilities. So here are those different types of white blood cells that I talked to you about. We have the neutrophils that are the first to respond to bacteria or a virus. And then we have the eosinophils that are known for their role in allergy symptoms. The basophils are known for their role in asthma. And then we have those lymphocytes that fight infections by producing antibodies. Last but not least, we have these monocytes that clean up all of those dead cells that are circulating within the body. So I just wanted you to have a pictorial view of these different types of white blood cells. So neutrophils in particular, they are a type of white blood cell that kill bacteria and help prevent infections. If your neutrophils are low, the medical terminology for it is neutropenia. And if your neutrophils are elevated, it's neutrophilic leukocytosis. And then we have this normal range here of 45 to 75%, again, depending on which laboratory facility that's running your labs. An absolute neutrophil count, or ANC, shows how well the body fights infection. ANC is monitored for those that are taking hydroxyurea. So we look at this value to see whether or not we need to titrate or change the dose of hydroxyurea. We don't want that ANC number to be low with those individuals who are taking hydroxyurea, which is a modifying treatment for sickle cell disease. And then I just went ahead and put a picture here of hydroxyurea, just so individuals can see that there are capsules and how it looks. So platelets. Again, platelets are those blood products that help to prevent blood from clotting and prevent you from bleeding. So if your platelets are low, the medical terminology is thrombopenia. And if they're high, it's thrombocytosis. And so again, here's that normal range. So we're looking at that. We want to make sure that your platelets are not too high or too low that puts you at risk for excessive bleeding or excessive clotting of the blood itself. And here we just have a depiction of a hemoglobin electrophoresis. So a hemoglobin electrophoresis is actually a blood test we use to determine whether or not an individual has sickle cell disease or sickle cell trait. As we started the conversation, there are two different types of hemoglobin that are present in regards to sickle cell disease, and that's the normal type, and it's considered type A, and it's the sickle type, and that's the S type. A carrier makes both types. So a carrier would be someone who has sickle cell trait. They would have a normal A gene for hemoglobin and a S for sickle. A person with sickle cell will have the S type. They will have two of those S genes. And someone with normal hemoglobin will have A type. And so we can just see here what the phenotype is in regards to what that hemoglobin electrophoresis looks like. So down to newborn screening, which I feel is extremely important. So what is newborn screening? It's actually a public health program in the United States and many other countries used for screening infants shortly after birth. And this takes place between 24 to 48 hours. And they're screening these infants for conditions that are treatable, but not clinically evident in the newborn period. So what that means is they're screening for disease processes and other conditions that you otherwise wouldn't see in newborns. And these are conditions that will later arise as these babies begin to become older. And so here, this slide is just a little bit dated because it noted that it's 50 years of newborn screening. Here in the United States, we're actually at about year 58. And so this slide also depicts that most states screen for sickle cell disease or screen for the newborn screening, which has a list of different conditions that it screens for. But actually all 50 states in the United States are actually screening for sickle cell disease, with the last one being somewhere around 2018. And so now all 50 states are including newborn screening with every single infant that is born, and that particular test is done between 24 to 48 hours. So again, every baby born in the United States receives newborn screening. And it's one of those tests that every family can expect. They know that it's going to happen. And then the results are received about 2 to 3 weeks later and discussed with each family by their primary care provider or pediatrician. So what does the newborn screen detect? So I have several slides here. This table 1, and all of this is derived from the American Family Physicians article. But the first thing that the newborn screen can detect are amino acid disorders. And they're listed here. There are several that are actually detected. Table 2 shows fatty acid oxidation disorders that can be seen with these particular screenings. So we noticed that there are a number of different conditions that can actually be detected through this screen. When we move along and see table 3, there are some organic and acid disorders as well. And I know for the sake of being able to actually see what there are, you probably can't, but I really wanted to show just how advanced and expanded this newborn screening can actually be. Table 5, we can see some endocrine disorders that are actually detected, and then some miscellaneous and multi-system diseases. So I want you to keep in mind that even with this screening, that the things that are detected can be congenital heart disorders, along with all of these endocrine and genetic disorders, as well as a hearing strain. Last but not least, that really coincides with what we're discussing today is that newborn screening also picks up hemoglobinopathies, specifically sickle cell disease, sickle cell anemia. And even with this chart here, this table, it shows that the organ or system that is affected here is the central nervous system, the heme, kidneys, and lungs. But we know for those of us who are bringing awareness and study sickle cell disease, that it's more than just the central nervous system, the kidneys and lungs. It literally affects every single organ in your body, and from head to toe, literally, as well as all of your blood. And so some of the signs would be anemia, infection, and pain. And also the neurodevelopmental effects that, if not treated, they're variable, but mostly associated with increased risk for cerebral vascular accident or stroke. So it's very important for us to be able to detect this when the infants are born. So we better know how to plan for treatment and start treatment sooner. So how is this particular test performed? Well, it is performed by a procedure or method called a heel stick. And with this heel stick, we can see that the baby's heel is actually poked here or pricked with a lancet to extract the blood. It's wiped or cleaned away. And then there's this card that you actually have to place those blood right on that card. And so again, it's more than just drops on a card, because it helps us to really detect a number of different genetic, endocrine, metabolic types of conditions that these children may have. And it really helps providers to better plan for how to treat for these disease processes. And again, don't forget that it also tests for hearing loss in these babies. So why newborn screening? Why is it important? Why is it important? It helps detect health conditions that otherwise would not show up in the first few months of life. It gives the positive results, actually allows for initiation of appropriate treatment plans. And it helps to build awareness and advocacy around some of those rare conditions that we typically don't hear about that often, and really help to pour into what we can do to make these conditions better in regards to a better quality of life. So in summation, we talked about the CBC and what it is, what it's comprised of. It is a group of tests used to evaluate the cells circulating in blood. Those consist of red blood cells, white blood cells, and platelets. It's also used to detect a variety of diseases and conditions, such as infections and anemia. And it acts as an important tool for decision-making and health management in sickle cell disease, specifically in regards to this discussion. Newborn screening is the leading tool in detecting health conditions, and including sickle cell disease and hearing loss. And it's also important because you're able to detect other disease conditions that you otherwise wouldn't know until later in life. That concludes my presentation on sickle cell disease and those labs that are associated with it, as well as a little bit of information about the newborn screen. And we can have questions now if you're ready for questions.
Thank you so much, Dr. Henry. That was very informative. And I always go back to watching this, because when I'm listening, like, did I miss that? Did I miss that? I'm glad it's recorded on Facebook. So I'll go back and sit another hour to watch. We have a few questions. I'll come back to Nomesh's questions in the chat box, but I think I'll go to a question by Tiona. I'm sure you know Tiona Woolford on Facebook. She's asking, I think you talked about
reticulocyte. Yeah, I mean, it's one of those things, especially in the emergency room. And so for sure, you may typically hear retic count instead of the entire term reticulocyte count.
That's what she actually put that.
Yeah, retic. Yeah. So it's one of those things, when you think about it, if you have sickle cell disease, then you are likely to have a lower hemoglobin, a lower hematocrit, which makes you anemic, because you're going to have that process of hemolysis. So those red blood cells are consistently breaking down, right? So if they're consistently breaking down or going through their process of hemolysis, your bone marrow is saying, hey, we need more red blood cells out in circulation to kind of help give you what you need. And so while those red blood cells are being made in the bone marrow, they're like, oh, stop. Take a pause for a minute. We need you. Let's go. And so that's why they're immature and they're in circulation. And just because your reticulocyte count is high does not mean that you are in crisis. So if it's on a lower end, that does not mean that you're not in crisis. We have to listen to our patients. If they're telling us they're in pain, if they're telling us something feels different, I feel weird, is something's not right. Those are the things that we listen to, not necessarily just those numbers.
Well, that's very informative. Thank you for that. I've got a few questions that I'll just go through in terms of the tests we spoke about. You spoke about the different types of sickle cell disease that take tests. We tend to see that the most common, obviously, is the sickle cell anemia, but we also have hemoglobin C and beta thal sickle cell. But there's so many different forms of sickle cell and disease. We don't really hear much about them. Even the people that when you're on social media, when you're sort of just seeing the comments, different chat boxes, different groups, people don't talk about different types of sickle cell disease. Is it that it's not very common, or why don't, especially clinicians, talk about this much?
That's a really good question, because the truth of the matter is, in regards to genotype, is what we look at. Genotype is the type of sickle cell you have. They are all very common. The thing is, the one that historically has caused more severe complications has been SS, typically because it's fewer red blood cells and more sickle cells. Their oxygen levels are lower, they're more anemic, and so that's why we would typically see them having more crises, more complications. But that can be the case for all genotypes. So I said that to say this: typically most research studies will include those who have SS or SC. Now, when we talk about hemoglobin SS, SC, beta thalassemia, S plus, it goes on and on. There's so many different genotypes. They're all pretty common in that regard. So hemoglobin S thalassemia, hemoglobin S plus thalassemia, they're all very common, but a lot of the research was really evolved around SS and SC. And I'm even noticing that that's changing, where a lot of research now is including multiple genotypes. And so that's a good thing. So it's not that it's just not talked about that often, or it's not something that's common. It's just the research has really revolved around two specific genotypes.
Talking about the bone marrow for somebody living with sickle cell disease, this came up, I think, when our child was having a bone marrow transplant. One of the things that the oncologist spoke about was that the bone marrow for people living with sickle cell disease is very rigid in terms of, especially if people grow older, in terms of the treatment. Why is that? Is it because it's working continuously compared to other blood disorders?
Exactly. That has a lot to do with it. So if you remember previously in the discussion, I talked about someone without sickle cell disease will have red blood cells that will live 120 days. Those with sickle cell disease, that ranges between 10 to 21 days, meaning they are constantly making red blood cells. So when you think about it, that bone marrow is really in overdrive all the time, consistently pushing out red blood cells and producing more and more red blood cells. And so then you get what's called this bone demineralization that takes place, and the bone begins to get weak and things of that nature. And that's why you would see a lot of individuals with sickle cell disease will have avascular necrosis, or AVN, because that bone is consistently working, and then there's a decrease in circulation in that bone. And those they really feel it in those hip bones, shoulder bones, knee, those joints, those major joints, because it's hard to get that circulation through. That bone marrow is in overdrive, literally pushing out red blood cells to compensate for the anemia that's taking place.
One of the other questions I received was the issue with the sickle cell trait. So I've now been, especially the late last year and early this year, focusing much also on the sickle cell trait. For me, I thought I was one alien who had a reaction when when I was pregnant with my youngest, because I got sick, and later on, after listening to other stories as well, and listening to people like Dr. Tomia Austin talking about how people who've got sickle cell trait can also be impacted by sickle cell disease-like symptoms. That's what happened to me when I was pregnant. At what point do the tests or the percentage of the sickle cell trait trigger those symptoms where you actually start feeling some of the symptoms like you have sickle cell disease? Because I know for me, even now, I think just the other day I was telling my husband it was so cold. I don't know what happened to the water. My fingers started hurting, like the bones inside, because I touched cold water for too long. So at what point do the sickle cell trait percentage start giving you those symptoms? Is there explanation for that, or every person is different?
Yeah, so statistically, I can't give a percentage because just like sickle cell trait is very individualized. But what I do want to say is those with sickle cell trait, if you're feeling certain symptoms, don't dismiss it. It truly can be a symptomology of your sickle cell trait. And this is why I say this. Ironically, a lot of people don't realize or understand that when you have sickle cell trait, you actually have sickle cells circulating throughout your blood. And so that means that you're having those same red blood cells that are deoxygenated, don't have enough oxygen in them going throughout your body. And so one of the complications that is discussed a lot with sickle cell trait is exertional sickling. So if you're exercising or if you're in strenuous conditions, sometimes you can feel faint and pass out and things of that nature. If you're at high altitudes for some people with sickle cell trait, like flying long flights, they begin to, feel achy, so to speak. I've heard a lot of patients say, "Oh, it really wasn't a lot of pain. It was more achiness for me." And so that can definitely happen. So still staying hydrated, things of that nature, decreasing stress, just like someone with sickle cell disease should do as well, those types of things. So in regards to the percentage, it's individualized for sure. And again, a lot of people don't know they have sickle cell trait, which
Yeah,
is why we need to do trait testing.
I know. They don't. You just feel funny. You just start collapsing. True story here. When I was younger, I used to be so anemic. I used to collapse at school. And I didn't even know that it had anything to do with the sickle cell trait until I grew older. So, well, thank you so much. That's very informative. Coming back to our main subtopic about newborn screening, first question, how accurate are the tests, especially in America? Because I know other places maybe we say it might not be very accurate if it's maybe in the developing countries. But how accurate are the tests if you do
In,
that
in
newborn
the
screening?
in the United States, they're pretty accurate. In regards to maybe putting a percentage to that one, it is closer to that 90% accuracy. There's always room for error whenever we're doing any type of laboratory test. And then, of course, it's the operator, the person who's actually making sure that they're filling those circles in completely with blood that I showed you. They have to be completely filled, not half filled and things of that nature. Otherwise, it needs to be done over because they don't have enough specimen to actually run the test itself. But it's pretty spot on. And that's how we detect those individuals with trait and sickle cell disease specifically because of this conversation. That's how it's detected. Those results come back in about 2 to 3 weeks. And then it goes through a process of the provider finding out. It goes to the state. So that's another thing. It's state mandated. It's not all 50 states are doing the same thing. It's the same test, but they are mandated. They were all mandated at different times, if that makes sense. And so each state has a way of making sure that those parents get the results that they need from those tests if they're a positive test. But in regards to sickle cell disease, it's been spot on. And that's how we know.
And in America, so all babies born, whether, whatever race you are, they are tested for sickle cell disease, right?
It does not matter what race, because here's the thing: they do and here in the United States, we do the newborn screening, and it consists of a number of different tests, which includes sickle cell disease. And we have to also be cognizant that sickle cell disease is not predominant; it's not all African American or Black individuals who have sickle cell disease. We have to think about, the Mediterranean region of the Middle Eastern and, Indian and all these different ethnicities. And so everyone is tested. If you are born in the United States, it's just part of that whole newborn process where you're tested within 24 to 48 hours of birth. It's done. So regardless
Well,
of race.
so sort of a bit of sidelining here, but I'll just ask about prenatal screening. Is it also mandatory in the United States?
Mandatory is a very sticky subject when it comes to that. So definitely recommended. And the reason I say mandatory is because there are some individuals who just don't get
You have to do
prenatal.
it. Yeah.
Yeah, they just don't do it.
But
It's
is it
not.
offered? Maybe the right question would be, is it offered
Yes,
for every pregnant woman?
100%. It is. It is offered 100%. Now, if individuals, you know, um, go and get that prenatal care that they need, that's one thing, but it is offered for everyone. It is.
So thank you so much. So in terms of going back to newborn screening, well, within time, almost time, in terms of newborn screening, so once the babies are tested positive, they have the sickle cell disease. At what point do the doctors start treatment? Is it right there and then, or do they wait until they're in the 5-6 months mark?
No, typically one of the main treatments is penicillin. It's an antibiotic to help decrease infections, and so that treatment is started pretty quickly. They are monitored for a few months or whatnot, but treatment the whole point of having this information is so the treatment plan can start being produced, and you can initiate that cascading events of how we're going to treat. And so it's not a watch and wait situation. It's this baby has sickle cell disease. This is the treatment plan we're going to do. And so let's go ahead and initiate what we need to do for this baby. Yeah.
Thank you so much for that. I want us to be on time. We've got a question here by so Namesh is joining us from India. I'm not sure how or conversant or how you're okay discussing different sickle cell drugs that are on the market. Talking about Adakvil, he's got a question. How is I think what he meant was, is it beneficial for people living with sickle cell disease, and how does it control the pain crisis? If you're comfortable to answer that.
Comfortable. I will have a disclosure in saying that this is Dr. Henry making this statement, and not a statement specifically for the pharmaceutical company that has produced crizanlizumab or Adakvil. And so some of their studies have shown to be beneficial in more than 50% of individuals who were on the study actually had a decrease in pain. And so that's important. It's important to know what this research shows. So it does help decrease pain, but the caveat of that is that some of these injections, for some of the people, some of those side effects are actually bone pain or back pain and things of that nature. So getting through that process. Most of the side effects are a little bit of pain, maybe headaches. I see some side effects here. Headaches, a little bit of arthralgia, which would be some bone pain itself. And you think, okay, well, I'm getting this injection to help decrease my crises, but it still has pain. But over time, what I've heard from the patients who are on the medication is that arthralgia or that bone pain that they have typically subsides over time.
And is it taken in combination with hydroxyurea for those that can tolerate?
Oh, yes, most definitely. And that's another good thing about the study itself. It was those individuals who were in the study, some of them were on hydroxyurea.
Okay. Well, thank you so much for that, Dr. Henry. I can't believe how 1 hour goes. I was like, we're going to do 30 minutes. No, we didn't. It's almost time. Yeah, thank you so much, Tomesh. Well, we've got 2 minutes to go. The last questions, just last questions before you go. I love what I do. I've got a lot of advocates watching us online now. What message do you have for people that are always trying their best to raise awareness, including yourself as an advocate? What can we do more, and how else can we just enhance our work?
The first thing I would say is don't be judgmental of those who are living with sickle cell disease. It is a very individualized disease process. Everyone will not show up presenting the same way. have some compassion, extend some grace, understand that this is a disease that they are born with and they cannot control the pathophysiology that's taking place in the body. Otherwise, they wouldn't have this disease. And so bringing the awareness and advocacy around making sure that they have what's needed in regards to health equity, equality, and just the resources is so important. You know, this is a chronic disease process that attacks literally every single organ in their body. And so we have to make sure that we are treating appropriately. Treat them as if they're coming in someone who's having a heart attack or someone who's having a stroke, which a lot of individuals with sickle cell disease are predisposed to having stroke. And so we have to just make sure that they're not stigmatized and singled out and looked upon as if they are only seeking drugs or just want pain medicine. They're needing this medicine because they are in excruciating pain. And if we're not questioning other diseases that require pain medicine, why are we doing this for those who live with sickle cell disease? So I would say be a change agent. You know, do your research. Talk to someone, caregivers and patients who live with this disease, and really get a clearer understanding of what that looks like and really be a force of change for this population.
Well said. Thank you so much.